MedComp presents the translumbar percutaneous tunnelized technique for insertion of the split cath in the inferior vena cava for chronic hemodialysis care. The procedure is performed in a standard radiology suite, and the surgical team is fully gowned and masked.
Today we are going to implant a double-lumen polyurethane dialysis catheter into the inferior vena cava using the translumbar approach. Our patient is a 38-year-old woman with end-stage renal disease due to lupus nephritis. She has failed peritoneal dialysis and has been undergoing hemodialysis for the past 18 months using internal jugular catheters. Both external and internal jugular veins, as well as the left innominate vein, are now occluded. She is scheduled to receive a right forearm fistula. In the interim, she will receive dialysis via the translumbar catheter.
The patient is placed in a prone position on the table and is prepped and draped. Be sure the sterile prep on the patient extends all the way around anteriorly to the midline so the entire right flank is sterilized. Conscious sedation may be used for this procedure. Anatomical landmarks, which are the middle of the iliac crest and spine, are palpated. The middle of the iliac crest is the site of the initial access. A hemostat is used to mark the iliac crest, which can then be confirmed with fluoroscopy. Now, lidocaine is used to anesthetize the site. It is important to inject the lidocaine as deeply as possible along the path to the inferior vena cava. Next, a skin nick is made with the number 11 scalpel, wide enough to allow passage of the vessel dilator and the sheath dilator. A two-part 18-gauge by 20-centimeter trocar needle is used to access the vein. Fluoroscopy is used to guide the needle. The needle is advanced using the 45-45 approach. That is, there is an approximate 45-degree angle cranially and a 45-degree angle toward the spine. As the needle is advanced nearly halfway, additional local anesthesia is given. Once the needle approaches the spine, have it pass just anterior to the vertebral body. Continue to advance the needle under fluoroscopic guidance so that it passes just up to, but not across, the midline, looking in an antero-posterior projection. With contrast media in the connector tubing, aspirate and pull the needle up. When blood return is achieved, contrast media is injected under fluoroscopy to confirm placement in the inferior vena cava. Now, a .038 by 120 centimeter Teflon-coated flexible-tipped guide wire is used to enter the vessel. The needle is removed, and a 5 French vessel dilator is passed over the guide wire and into the inferior vena cava. Using the fluoroscopic image, the guide wire tip should be at the junction of the right atrium and the inferior vena cava, because the desired final placement of the catheter tip is just above the eustachian valve, extending slightly into the inferior portion of the atrium. While the tip is in this location, pull it back to the venotomy site and bend it again. This is the desired length of the catheter from the venotomy site to the tip of the catheter. Next, a stiff guide wire is passed through the dilator. Care is taken to avoid air embolism. The guide wire is passed into the inferior vena cava. Once again, placement is confirmed by fluoroscopy. A flow switch is passed over the guide wire and locked in place. This assures that the guide wire does not move during the tunneling procedure. Now the catheter is flushed and measured using the previously bent guide wire. This determines how long the tunnel will need to be. Measure the desired tunnel length on the patient and locate the exit site. The drape is cut to expose the path of the tunnel. Usually the tunnel is approximately 10 to 15 centimeters and exits in the mid-axillary line. Begin to anesthetize the exit site with lidocaine. A small nick is made just large enough for the catheter and cuff to pass. Ideally, this exit site should be snug around the catheter to minimize bleeding. Now the entire subcutaneous tract of the tunnel is anesthetized. Next, a blunt trocar is used to create the subcutaneous tunnel. In some cases, as in this demonstration, a counter incision is used and the tunnel is created in 2 steps as seen here. The catheter is pushed onto the trocar, not twisted, as this may cause the catheter to kink. Now the trocar, tunneling tool, and catheter are advanced as a unit and pulled through the tunnel until it is at the exit site and the cuff is inside the tunnel. Now the switch and dilator are removed, leaving the wire in place, and a 16 French by 30 centimeter tearaway introducer sheath is fed over the wire. Again, position is confirmed with fluoroscopy. The dilator is removed, being careful to occlude the opening. The catheter is fed into the tearaway sheath. Do this as quickly as possible to avoid any air emboli. Continue to advance the catheter as the tearaway sheath is removed. Once the catheter is in, palpate this area to assure there are no kinks and there is a smooth turn. Again, catheter placement is confirmed with fluoroscopy. The distal tip should lie just inside the junction of the inferior vena cava and the right atrium, and the proximal tip approximately 4 centimeters above. This prevents blood recirculation during hemodialysis. The catheter is flushed and aspirated to ensure good blood flow and is locked with an anticoagulant. The incisions are sutured, and finally, the catheter is sutured in place.
This antero-posterior abdominal radiograph shows the catheter after placement. The subcutaneous tunnel extends around the right flank to the venotomy site. The catheter extends through the retroperitoneum from the venotomy site to the inferior vena cava. Once in the inferior vena cava, it travels all the way up to the caval atrial junction. Note that the split catheter tips span the caval atrial junction and are above the eustachian valve for optimal catheter function.
The MedComp split cath with translumbar insertion is beneficial to both the patient and the caregiver. The translumbar approach affords venous access when traditional access points are no longer viable. The 2 free-floating lumens dramatically improve flow rates compared to traditional plastic or permanent cannulas and allow blood flows of 400 to 450 milliliters per minute with acceptable venous resistance and long-term patency. Subcutaneous tunnel may reduce migration of microbial activity. For more information on this and other MedComp products, contact your MedComp representative.